So we are moving to the very left of the MS spectrums, and we will talk about radiologically isolated syndrome and maybe early treatment, which could mean escalation therapy, but we will see that together. So I don't have any disclosures. So you know very well this cartoon about MS with the first clinical event and then more relapses and finally the progressive disease which starts sooner than the progressive, than the worsening of the symptoms. And since 29, we have described the preclinical phase, which is named radiologically isolated syndromes, but we knew before this definition that there were some MRI activities on the cartoons representing MS with this arrow before the first clinical event. You know very well this cartoon. And of course, the disease is not starting with the first T2 lesion. It starts well before with the at-risk population, which means environmental exposure or familial risk. You know this very well. The point with RIS is it's very, very rare, and you have to identify among all the individuals who have a T2 lesion, white matter T2 lesion, who has RIS. It's very, very rare. You know that for an individual in his 30s, more than 25% of this cohort will have T2 lesion, non-specific T2 lesion, and above 65, it's more than 90% who will have T2 lesion, and less than 0.1% will be a true RIS. So the work is to find out which one is a real RIS. So we will start with a clinical case. This is a woman from our MS clinic. She's 20 years old. She just had a cranial trauma and went for a brain MRI, and you can see on this FLAIR MRI that these T2 lesions are very suggestive of MS. They are fulfilling 25 MS DIS criteria with more than 3 periventricular lesions, juxtacortical lesions. You can also see that there is at least 2 gadolinium enhancing lesions. So this MRI fulfilled the 2005 DIT criteria for MS. And I will not ask you to raise your hand, but I might ask you, do you think that this young woman has MS? And if you don't think she already can be classified as having MS, is she at risk of developing MS? So we will move forward and answer these 2 questions together. So after the publication of the Italian, Spanish, French, Turkey, and US cohort describing that there were people having T2 lesion very fulfilling the DIS criteria for MS at that time, were the 25 DIS criteria, Darren Okuda in Neurology published the first radiologically isolating syndrome criteria, defining that the people fulfilling the 2005 DIS criteria for MS with a normal neurological examination with no history of symptoms, then it was named for the first time the radiologically isolated syndrome. And since then, we had existing diagnostic criteria recognizing that these subjects were at likely risk for developing MS, and we started to collect all these cases worldwide to see how they will enter MS and the risk factors and the risk stratification for developing MS. So this is a summary of 5 publications of this cohort. The first one, I don't think I have a pointer, but the first one was the 5 years study published in PLOS in 2014, describing that 35% of RIS fulfilling 2009 criteria will develop a first clinical event. And then we followed the same individuals, and at 10 years, a majority of these individuals will develop clinical MS, either on a relapsing form or for 10% of them on a progressive form. And then we start a prospective cohort demonstrating that at 2 years, nearly 20% of them prospectively followed will develop MS. So it's quite reassuring that we can say that RIS people, some of them, will develop MS. Is it MS yet without a first clinical event? Then we can answer the answer. We don't have the answer yet, but we will see if we can proceed. And then I just look at the RIS cohort at 15 years, and you can see that at 15 years, 72% of the same cohort will develop the clinical disease. There are risk factors. All the RIS people will not develop the clinical disease, and the risk factors are the young age, under 37 years. The CSF, so we are inclined to still propose to go to the lumbar puncture to see if there are some biological activity which can mirror what we have in MS, oligoclonal bands, and more recently, increased kappa index. And there are some MRI risk factors we are defining at the time of the index scan. The first MRI, when you see the T2 lesion fulfilling the RIS criteria, if you have gadolinium enhancing lesion, infratentorial lesion, or spinal cord lesion, then you increase the risk to develop the clinical event. So we were able to identify a condition that could become a disabling chronic disease and maybe prevent a clinical disease with prescribing disease-modifying treatment very early during the asymptomatic phase of the disease. So as we said, most of the RIS will evolve to the relapsing form of the disease, nearly 10% of them to the progressive form of the disease. There is also a pediatric RIS effort, which is the RIS cohort, which demonstrated that RIS exists under 18 years old. The younger RIS was 3.2 years, and he developed MS at 9 years. And we also demonstrate that pregnancy in RIS is a specific condition to follow, because in the RIS consortium cohort, all the women experiencing a pregnancy enter the clinical disease after the delivery. So we have to very look closely at RIS women who are asking about having a baby. And we just talk about vaccination. We also demonstrate that vaccination did not have any impact, and COVID infection neither have an impact on entering into the clinical disease. So as for the risk stratification, this is a result of the prospective cohort. You can see that if at the baseline scan, the individual don't have any risk factors, so you don't have any oligoclonal band in the CSF, the individual is older than 37 and no spinal cord lesion, no infratentorial lesion, no gadolinium enhancing lesion, either on the baseline scan or during the follow-up, then at 10 years, nearly 30% of them will have a clinical MS. So it's not really reassuring. But when we can say is that at 10 years, if these individuals have all the risk factors, then you are quite sure that he will develop the clinical disease, either on the relapsing form or the progressive form. And if you look at all the risk factors which has been described, this is a paper from Ruth and Mary published in Nature Neurology, you can see that the estimated risk to develop MS the greater is a radiologically isolated syndrome if you compare to all the risk we have learned from the MS history. So what about age and ethnicity? This is unpublished data, but just to show you that if you look at the blue graph, which is RIS who will not evolve to the clinical disease, compared to the orange graph, which is RIS who will present the clinical disease during the follow-up, you can see that RIS subjects who convert are younger. So they have a higher risk, but they are younger. And if you look at the right inside of the slide, you can see the cumulative probability of having a first clinical event depending on the decades of the patient when you see him in your office. And you can see that if you focus on the blue line, the individuals in his 20s at 10 years will have an 80% cumulative probability risk to have a clinical event if he has the index scan in his 20s. And if you focus on the purple line, which are the people in their 50s, so the older part of the cohort, you can see that at 10 years, nearly 40% of them will develop the clinical disease. And this is a very important message because we heard before, and we have a tendency to think that when you are over 50 and you have T2 lesion, even if these lesions are fulfilling the MS criteria, and the individuals has a normal neurological examination, you implicitly think that, oh, the risk is low. The risk is lower, but look at the purple curve at 10 years. 10 years, when you are in your 50s, then at 60 years, you have 40% to have a clinical MS. So this is an important data to remember. So is RIS people are at risk of developing a clinical disease? I think that I hope I convinced you that the answer is yes. But you know that the first paper about criteria was published in 2009. At that time, we were using for MS the 2005 RIS criteria, but now we are using the 2017 MS criteria. So for RIS and for incidental findings, one T2 lesion in a very specific location or two T2 lesions in very specific location, we are using for MS criteria, so one periventricular or one cortical juxtacortical or one spinal cord and one infratentorial. So the four very specific locations we are using for diagnosing MS. Could we apply this for RIS? So we looked at these cases we collected worldwide, and you can see on the first figure that the orange curve is representing the RIS 2009. So it's okay, at 10 years, more than 50% will develop clinical MS. But look at all the other who will not fulfill these criteria, so they have less T2 lesion. You can see that at 10 years, more than 30% will develop the clinical disease. So we have to look closely at these. And we looked at the risk factors, and we found the same. They have the same risk factor than the 2009 criteria, having spinal cord lesion, oligoclonal band in the CSF, and dissemination in time on follow-up scan defined by either new T2 lesion or gadolinium-enhancing lesion. And then, for the stratification of the risk, you can see that if you have only one T2 lesion or two T2 lesions, but we are talking of T2 lesion suggestive of MS, more than 3 millimeters, etc., then you can see on the green line that at 5 years, 15% of them, without any risk factors, will develop the clinical disease. And for all the other possibility, you can see 1, 2, 3 risk factors. The evolution of these people having only 1 or 2 T2 lesions will mirror the risk factors and the evolution of the 2009 RIS criteria. And this demonstration was the base of the revised RIS criteria published last year, and you can consider the diagnosis of RIS if the patient fulfilled the 2009 RIS criteria, what we called before the Barkov MRI criteria, or less T2 lesion, but you have to add risk factors. You have to add the CSF or the spinal cord lesion or the demonstration of active disease during the follow-up to increase the specificity you don't have with the MRI and 2 T2 lesion. So the point is to increase the specificity and not consider RIS in every T2 lesion you can have in your clinical practice. Because of course the risk of misdiagnosis of MS and of RIS without clinical symptoms is very high. This is the great works from Andrew Salomon or Peter Calabresi, which demonstrate that there are MRI mimics, and you really need an expertise in lesion location and in the culture of the MS and the RIS criteria to not overdiagnose and, of course, overtreat people who will, at the end, will not have MS or RIS. And there is all the literature about prodromes. I don't have time to detail this. You believe in prodromes or you are not believers in prodrome, but I think the confusion is around the MRI motifs in the RIS cohort. This is the top 5 reasons for having an MRI and then a diagnosis of RIS. Most of them, it's for headaches, tension headaches, or migraine. Then mood disorders, non-specific mood disorders, and then non-specific ophthalmological or ENT symptoms. You have also more than 10% of people followed for another disease, and you are starting with a normal brain MRI, and then you see 1 T2 lesion, 2 T2 lesion, and this is the birth of the RIS, we can call this, and of course the cranial trauma, and all the non-specific symptoms like chronic pain, fatigue, gastrointestinal disorder, and then you think that it remembers you all the literature about prodromes and of the demonstration that the years before the diagnosis of MS, some people are increasing their healthcare use because they are feeling that something is not right. But in all the literature about prodromes, these people didn't have an MRI. So you have to be very careful to not misunderstanding the prodromes literature with the RIS literature, because so far there is no study which looked at the MRI in the prodromes cohort. So the relation with prodromes or unusual MS presentation and RIS is still pending. So if you remember the first cases, do you think she has MS? Yes? No? Maybe? You don't want to play? So we will look at what the expert, the MSologist, think about this and think about RIS. Well, in 2008, it was 1 year before the neurology paper of Darin Okuda. You can find this very, very interesting paper from David Miller, who described a type 5 CIS and say, well, we know that we have some individuals with no clinical presentation to suggest demyelinating disease, but MRI is suggestive. 1 year before the neurology paper, this is RIS. So this is, I think, the first paper officializing that it exists. But then, when you looked at the phenotype classification, the Lublin classification, or the MS McDonald criteria, you can see that in 2013 and in 2017, the expert did not consider RIS and didn't want to discuss the fact that RIS could be the first step of MS because the first clinical attack is required to diagnose MS. So, can we move forward now? Well, you have to wait to the ECTRIMS 2024. Xavier Montalban will present for the McDonald Diagnostic Criteria Review group the result of the new meeting, and we are not allowed to discuss about this till this presentation, but we are allowed to say that we discussed again the fact that we could include in some very specific situations some RIS as having an asymptomatic multiple sclerosis. We don't have the result now. We are not allowed to discuss what we discussed then, but we are allowed to say that some changes might happen in the next ECTRIMS. And so maybe we will be able to consider that the radiologically isolated syndrome in its active form, define active. Active could be with the demonstration of biological biomarker, MRI biomarker. We have to define active. Could be the first step of the new phenotype MS classification. And then I think I have some time. I am looking at Caroline, 5 minutes to talk about prevention. So since 2022, we have 2 prospective double-blind randomized studies for 2009 RIS criteria. So it was before the revision of the criteria with 2 different DMT, dimethyl fumarate for the RIS study and teriflunomide for the TERIS study, showing that we can have an impact on clinical MS. And we are very proud to have 1 Swiss center in Bern with Robert Hoppner as PI. It was a bumpy start for the TERIS study, and we asked a lot of centers, but we have to start, and it was before what we knew about risk factors, so we are a little bit frustrated with the result. But anyway, it was carbon copy study presented at the ECTRIMS and the American Academy, and you know the result. You have 80% of risk reduction with dimethyl fumarate on 2009 RIS cohort, and 72% of risk reduction with teriflunomide. So it's a great result, and it's a key unmet need to prevent the first clinical symptoms. But it's not for all. It's not for all because at the time we launched these 2 studies, we didn't know about all the risk factors. We didn't know about the spinal cord lesion, about the CSF, and we did not collect this data in the RIS and the TERIS study. So we are not able to present you the treatment effect depending on risk factors. And it's a nightmare because we should have to, but we did not know what we know now about the risk factors. But anyway, even if it's not allowed, I can show you the comparison of the RIS population and the TERIS population. You see that we were able to include about 80 people, and TERIS individuals are way much and statistically younger and statistically more active with more gadolinium-enhancing lesion. So this is something to think about. But anyway, if you remember the Kaplan-Meier curve, you can see that the treatment effect is way higher than in the phase 3 study with the same product in relapsing remitting MS. So just to focus on biological markers, this is a very nice review of Manon Rival, who talk about all the MS spectrums, but also RIS, and I added, after the publication, the kappa index, which has been published in N2, and the GFAP, which just has been published in MSJ, and you can see that they are quite mirroring what we know about MS. And the imaging marker, too, with the central vein sign. This is a way, if you apply the 6 select rules, so you find 6 CVS on a brain MRI, then you will increase the specificity as well as the oligoclonal band in the CSF. This is a message, very important message. If you are not able to have the phase MRI to look at the central vein sign, then you can go to the CSF. But if you don't have the CSF, you can go to the MRI, and the select cis is doing as well as the oligoclonal band. But look at the last result. If you have the CSF and the oligoclonal band, the specificity is 100%. So it's a key message. So what to consider next? So we have to move forward to increase the specificity of the T2 lesion and to describe who is really at risk and who need to be treated, because it's a $100 million question. So we have, with the support of ICRA and with the support of ECTRIMS, we are launching this year the European RIS Consortium. And if you are interested in participate, please feel free to reach me, to send me an email, homing pigeon, whatever you want. But I really would like to increase and to federate all people about gathering RIS cases worldwide and looking at a different population. So far, the position paper about who should be treated and who should not is this. If you have the RIS criteria, then you have to look to the prognostic factors, so the age, the CSF, the gadolinium-enhancing lesion, the spinal cord, and on follow-up scan, the dissemination in time. And then you should discuss with DMT. It's not because you have 2 phase 3 studies that you are allowed to treat, because so far, this is not MS. This is asymptomatic people having T2 lesions suggestive of MS. So you are off-label. And if you are referring, I'm sorry, but I don't know how you work here, but in France, we have tertiary center, which is expert center. So we published a recommendation that each RIS, if you want to treat them, you have to present the case to an MS clinic. And you are not allowed to prescribe anything you want to anyone you want. And I'm sorry I don't have the timer, but I'm sorry if I was too long, but I want to thank the Côte d'Azur team, the French MS Society and French MS Observatory team, and of course the RIS family, and you have here my details. And I thank you very much for your attention.